Everyone, can you hear me okay? Am I loud enough? Perfect. So welcome to the final keynote address for today, for this afternoon. I've met a number of you. My name is Mohammed Saab. I'm a lecturer in University College Cork here in Ireland, and I'll be chairing this final session. We are joined by Dr. Peter Singer with us here live. The session will be approximately 40 minutes, perhaps, so we could open the floor for 5 to 10 minutes of questions, if that's okay. Thank you very much. So Dr. Peter Singer is a special advisor of the Director General, Dr. Tedros Ghebreyesus, and Assistant Director General of the World Health Organization. He co-chaired the transition team, was the architect of WHO strategy and its triple billion target, and supports a number of strategies as well, including the SDG 3 Global Action Plan. During the pandemic, he advocated for vaccine equity, and in the past, he co-founded two innovative organizations. Just to name a few, from 2008 to 2018, Dr. Singer was CEO of Grand Challenges Canada, which raised 450 million Canadian dollars to support 1,000 innovations in more than 90 countries, impacting the life of millions of individuals, with projection to improve the health of 11 to 35 million lives by 2030. I think if I continue, I'll be taking from the time for presentation. Just to end, Peter has published over 300 articles, received over $50 million in research grants, and mentored hundreds of students. So we're honored to have you with us, and I'll give the microphone to you. Thank you.
Well, thank you so much, Mohammed, and I also want to thank Nicola and Catherine, and it's really a great pleasure to be here and at the SIG conference and to bring you greetings from the World Health Organization. You know, I wanted to start, with your indulgence, by thanking you, all nurses and midwives, and yourselves individually, for your service during the pandemic and beyond. WHO greatly appreciates and respects the role of nurses and midwives. For example, just during Dr. Tedros' term, WHO has appointed a chief nurse, Elizabeth Ero. The member states have approved the Health and Care Workers Compact just at the recent World Health Assembly. And we've, of course, launched the Nursing and Midwifery Global Community of Practice. And so these are just, if you will, proof points of a broader point I'm trying to make, which is the appreciation of WHO for the work of nurses and midwives. And as you well know, nurses and midwives constitute almost half of the global health workforce. I know your conference is on sustainable development goals and workforce, and you know, my key message actually in this talk is that leadership is the ultimate vaccine, and nursing and midwifery leadership will be critical, drawing lessons from the pandemic as we protect against future pandemic threats and conflict, and also as we importantly help the world and help our countries recover to the sustainable development goals. And I'll come to both of those things individually, but my key message is the respect and appreciation for nurses and midwives, and also just how important leadership is in general, and your leadership in particular, and the leadership of nurses and midwives in recovery to the Sustainable Development Goals. So in this talk, I'll talk a little bit about the lessons of COVID. I'll talk a little bit about SDG recovery, and then I'll come back to the theme of leadership. So to begin with the lessons of COVID, first point I think that is responsible to make is, as the song goes, it ain't over till it's over, and it ain't over. And we see the pandemic ebbing and flowing. We see the rates ebbing and flowing. And so, of course, we must remain vigilant, and nurses and midwives are key in the community to do that, which of course means keeping an eye on your local rates, wearing masks, paying attention to ventilation in crowded indoor spaces where it's necessary to do so, maintaining booster doses and vaccination, focusing on the number of contacts when the rates are high, focusing, of course, on diagnostics, rapid testing, but also genomic sequencing and surveillance, and drugs when appropriate, when people test positive. And most of all, and this is the theme I'm going to come to, is advocating for equity. Because equity is at the heart of the Sustainable Development Goals. And in fact, there are 3 lessons from the COVID pandemic. And those 3 lessons are equity, equity, and equity. Those are the lessons of the pandemic. And let me just illustrate that with 3 examples. The first example is that of racialized and Indigenous communities. For example, the Black community in Toronto organized, insisted that disaggregated data be collected, was able to demonstrate, of course, the much higher rates of COVID infection in their community, advocated for enhanced initially public health measures and then vaccination. And you see similar stories playing out in Indigenous communities around the world, and of course in other racialized communities. So there's a very strong equity story there. And at times that's a very negative story, and historically it's certainly been a negative story, but there's also examples of positive action on equity in racialized and Indigenous communities. And the key there, as I was saying earlier, is leadership, because leadership, of course, occurs at all levels. And in this case, it was the leadership of communities and in communities that is so critical. And the communities theme is so vital for the future pandemic preparedness and the lessons of the pandemic, because pandemics start and end in communities. The second example of equity I'd like to give you is actually yourselves and us. It's essential workers, including nurses and midwives, but of course not limited to nurses and midwives, health workers generally, but all essential workers. And the importance of equitable treatment of essential workers. And as the Global Health and Care Compact that I mentioned earlier talks about, the reciprocal obligations for protection of health workers, be that through PPE, be it through vaccination, be it through public health measures or other measures, because some people can't stay home and Zoom to work. And that includes many of you and your colleagues and many health workers around the world, of course, because healthcare is a high touch activity. The third example I'd like to give of equity in the pandemic, and to me, this is really the central theme, is the example of vaccine equity. At the moment, more than 1 billion people in the world remain unvaccinated. 13% of the population in low-income countries has been vaccinated, compared to, of course, more than 70% in most high-income countries. And 58 out of 194 WHO member states, only 58 have reached that 70% target. So there's huge inequities in vaccination around the world still. Initially, that was issues in supply. And it will again be issues in supply in any future pandemic as things gear up. And now it's issues in distribution and demand, of course, and acceptance and misinformation, all of which WHO is very focused on addressing. I think that the story of vaccine equity has not only sadly cost many, many lives as very high-risk people, including health workers, were not protected in low and lower middle income countries during the pandemic, It's not only a story of, sadly, unnecessary deaths, and there were many, many unnecessary deaths. It's also a story about the limitations of our model of development and actually how we think about global health. You know, often we think about global health as a charitable exercise, but what vaccine equity really shows is the need for self-reliance. Essentially, countries, at least at the regional level, need to be self-reliant. They need to be able to make vaccines themselves. And I think that's the key lesson. So yesterday, for example, in the context of the Commonwealth Summit in Kigali, Rwanda, there was a groundbreaking for a local vaccine production facility that Dr. Tedros attended with many other leaders for a local vaccine production facility in Rwanda. Now, taken together, this message of equity, 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 and the inequities that we saw in many racialized and indigenous communities in the pandemic, among the deaths of essential workers, many of whom paid the ultimate price, sadly, among the deaths of unvaccinated people around the world and the vaccine equity. You know, fundamentally underlying these lessons of equity, I think it causes us to challenge certain assumptions that we really traditionally hold dear. I think it does cause us to reflect on deep questions about whether we really are our brother and sister's keeper, whether we really do love our neighbors like we love ourselves. And underlying these questions of science, of healthcare, are questions of value, equity, but not only equity. Underlying equity are issues of solidarity. Underlying issues of solidarity, at the end of the day, are issues of empathy and questions about our neighbor and what responsibilities and what love we actually feel for our neighbor, and questions of justice. So to me, these are some of the key lessons of the pandemic. Of course, going forward, there are now many discussions, many measures to try and do it better next time, if you will. WHO is leading a series of efforts on the global health architecture around issues like governance, around issues like finance, around issues like systems and tools, including countermeasures, vaccines, but not only vaccines, also diagnostics and drugs, and of course, devices. The role of medical oxygen proved to be extremely important and life-saving in the pandemic. But at the heart of it, the key lesson of the pandemic is a lesson of equity. And until we come to grips with the failures of equity and how one would address equity, which, as I mentioned, is central to the Sustainable Development Goals, how we would address equity differently and better in the future, these other measures rest on a less solid foundation than they otherwise would. Now, what I'd like to do is transition from the lessons of the pandemic to the issues of recovery to the Sustainable Development Goals. And there's no question that there is an unfortunate linkage there, because the pandemic has disrupted most health services, as you know all too well. Prior to the pandemic, the situation was, and you know, universal health coverage is a Sustainable Development Goal itself, a Sustainable Development Goal target and indicator. And universal health coverage, of course, means access to essential services without financial hardship. Prior to the pandemic, the situation was around the world that access to services, generally speaking, was increasing, but financial hardship was also increasing. So the first one's good, the second one's bad. What we saw in the pandemic was actually disruptions in access to services. So we got into a type of double whammy situation, if you will. And at the moment, WHO estimates, based on our own triple billion targets, which are SDG based, universal health coverage, healthier populations, which are all the things outside of SDG 3, which influence health, Just as an aside, by the way, you know, there's about 50 health-related indicators out of 170 something in the SDGs, and about 2/3 of those are in SDG 3. Arguably, the sharp end of that spear is the one on universal health coverage, which itself is an SDG targeted indicator. And 1/3 of them are outside SDG 3, things like water and sanitation, road safety, air pollution, climate, things that very much affect health that you're also discussing in your conference. Anyway, based on the universal health coverage billion of our triple billion targets and the healthier populations billion, the third billion, is, by the way, is protection from health emergencies. The world is only going now at about 1/4 of the pace it needs to be going. Countries are only going, generally speaking, at about 1/4 of the pace they need to be going to reach the health-related sustainable development goals by 2030. 1/4 of the pace. So this itself is not particularly good news. As I've mentioned, emergencies are a brake on SDG progress, and we saw this very clearly in COVID, but you also see it very clearly in settings where there's very significant conflict, like the war in Ukraine, Yemen, Syria, Tigray in Ethiopia, etc. These areas of conflict, these areas of emergencies, be it from pandemics, be it from conflict, retard, hold back, put a brake on SDG progress. And at the moment, we're going at about 1/4 the pace. WHO estimates that we could maybe double that pace by supporting countries in respect to better delivery, just being more rigorous about which countries are high burden, high impact on a particular problem, which interventions have the greatest effect, the greatest impact on a particular problem, and very importantly, which metrics to follow at the country level in a regular way. Not every country will want to follow 176 targets necessarily, or as their highest priority things, or even all 50 health-related targets. So a more rigorous approach to delivery can maybe double SDG progress. But that still only gets us going at half the pace. So then the question becomes, how do we accelerate further? And top of that list is innovation, better collaboration in the multilateral system, and better collaboration in the multilateral system. Just to take a couple of examples of innovation, as was very clear in the pandemic, medical oxygen was life-saving for people with COVID, but not only for people with COVID, also for children with pneumonia, for people undergoing surgery. So one innovation that was supported by WHO and in Somalia was solar-powered oxygen. You know, in rural settings, just to take as a concrete example, you can have so-called PSA, pressure swing absorption plants with high volume oxygen production, sorry, in urban settings where there are hospitals, infrastructure, et cetera. But in rural settings where there's poor electrification or unreliable electrification, we deployed solar-powered oxygen to hospitals, which saved hundreds of lives, as I say, not only of people with COVID, but also children with pneumonia. That constitutes 800,000 deaths a year or so of children under 5 across the world, helping people with surgery, et cetera. So that's an example. Another example of an innovation is something that you've looked at, I think, in your conference, which is mental health. Just as an aside, I think you know that 70% of the deaths in the world are caused by non-communicable disease. And one of the, in this case, heart disease, hypertension, cancer, et cetera. And one of the largest causes of burden of disease, of suffering, is mental health. And an example of innovation that can help accelerate access to mental health services is the Friendship Bench in Zimbabwe, which is culturally adapted to Shona language, essentially cognitive behavioral therapy, demonstrated in a randomized trial to be effective for mild, moderate depression and other mild to moderate mental health disorders. And that's cognitive behavioral therapy delivered on a park bench, essentially, by grandmothers in Zimbabwe. So innovations like these, and the first one was an innovation in a device, essentially solar-powered oxygen, but the second one was an innovation in service delivery, because the shortage, of course, there is the shortage of qualified mental health workers and psychiatrists. Innovations like these can help accelerate the Sustainable Development Goals beyond the 1/2 rate that we would get to, if you will, through delivery. Again, just like in the area of preparing against future pandemics and looking backwards, addressing the COVID pandemic, in the area of recovery to the Sustainable Development Goals, your leadership will be critical. The leadership of nurses and midwives, of course, will be absolutely critical in universal health coverage, in maternal child mortality, and in many other SDGs, because leadership is the ultimate vaccine. What I'd like to do is now transition to some almost closing remarks and leave lots of time for discussion. I also know it's Friday afternoon there where you are, and so it's not the end of the world if we stop a little bit early. I don't think you'll complain too much. But in terms of closing remarks, I just want to say, whether the issue is pandemics or conflicts, which I generally refer to as health emergencies, whether the issue is recovery to the Sustainable Development Goals and reaching those goals, especially in health, through the provision of health services, and those things are mostly inside SDG 3, or through the areas, the broader social challenges that influence health. And top of that list would have to be climate. Confronting these global challenges like climate, like pandemics, like conflict, like inequality requires leadership. And that's what we saw in the pandemic. That's what will be needed in protecting against future pandemics. That's what will be needed in recovery to the SDGs. And there is a critical role of nursing and midwifery leadership in that SDG recovery. It's very, very clear that that's the case. Even if you just go by numbers of health, up to almost half the global workforce, let alone even greater examples of leadership in nursing and midwifery through the pandemic. So it's a critical role. There's also obviously a critical role for young people. Many of you, I think, teach nursing and midwifery. So the way that you inspire your students, not only on the technical issues, but also on the ethical issues and on leadership, I think will be absolutely vital. My advice to young people, which might even be generalizable, my top line advice to young people is always find a problem and solve it. Just find a problem and solve it. And I think this particularly might appeal to the practical nature of nursing and midwifery. We saw many examples of that in the pandemic. For example, we saw groups of young people organizing and using information technology tools to match people in their communities with the availability of vaccines. At the time, vaccines were scarce. And many, many, many other examples. I gave the example of the Black community in Toronto, which, by the way, is a published case study in Lancet, led by someone called Kwame Mackenzie, if you want to see that one. Again, an example of finding a problem and solving it, but requiring leadership. And so this, I think, is really the essence of the lessons of the pandemic, the way we'll protect against future pandemics, the way the world will recover to the Sustainable Development Goals. And I think just a very, very central message to young people. And, another way of putting the same thing is what will matter at the end of each of our lives is not what it says on the outside of our tombstones, the title, the professor of this, the chief of that, but what it says on the inside of our tombstones, how we've solved problems in our community, how we've led, and how we've loved. Because love and empathy, in a sense, are the glue that holds together communities and the glue that binds us to actually even care about equity. So we do have some time for questions and for discussion. And again, if that runs short, I don't think you'll complain about Friday afternoon ending a few minutes early. But I want to close, Mohammed, if I may, just by thanking everybody in the audience for the work that they do. And as representatives of your professions of nursing and midwives, I want you to know very clearly that WHO greatly appreciates and respects the work that you do. And the work that you do is critically important, but it was not only important during the pandemic, it will be extremely important going forward because the world faces future threats in pandemics, in conflict that hold back the SDGs, and our progress on the SDGs is only a quarter of what it needs to be to reach them. And so leadership is going to be vital. Your leadership is going to be vital. And I want to end again by thanking you and expressing our respect and appreciation for the work that you do. Mohammed, back to you. And I take it you'll chair any question and answer that we might have from that end. And thank you so much for your attention and for this very, very kind invitation to your important meeting.
Thank you very much. Thank you very much. That was really thought-provoking, and I think the messages in there for us as nurses and midwives are very clear from SDG 3. So I'll open the floor to a few questions. I know I have a couple of them, but I'll give. Do you have any questions? What is the other microphone? I think this is louder. Yeah. Any? Oh yeah.
Dr. Singer, can you see us or no? Do we need to stand somewhere? Where?
I can see you now because you've moved to the screen and I can hear you very well. Thank you so much.
Hi, Dr. Singer. My name's Dr. Dan Other. And like you, I am also not a nurse, but I am here at this nursing conference. And I really appreciated your remarks, especially about equity and justice and the importance of leadership with nursing. And of course, you and I both know nursing is a noble and trusted and caring and empathetic profession. So I'm going to take you a little off script and ask you kind of a tough question right out of the gate. What is WHO doing to help ensure that a nurse becomes one of the future director generals of the WHO? If we're talking equity and we're talking justice, I would think that would be an important issue. So I'm just curious, as an advisor who's creating big level policy with the current director general, what ideas are you doing now to help advance a nurse as a future director general?
Well, I think, Dan, that's a terrific question. And, you know, let me go back to an analogy and then go directly to your question. You know, Dr. Tedros was the first director general from Africa in 70 years at the time of WHO. WHO is about to turn 75. He was actually the first health minister, believe it or not. He was the first non-physician. He's a public health, a PhD in public health. So there were a lot of firsts with Dr. Tedros. And I was actually had the great privilege of supporting him and being on his election team, if you will, before I came and helped him in WHO and co-chaired his transition. So one of the reasons I did that was I thought that first was important. I thought that it was extremely important to elevate the voice essentially of someone who'd had authentic experience. He often tells stories of growing up, and he grew up very poor. He grew up in conflict, actually, and experienced many of the problems he's trying to solve now. And I think that authenticity and that set of principles and calmness that you get from that experience has really served him well. So to me, that's a model of firsts, if you will. Now we come to nursing. And I think what's extremely important there is role modeling. So I think when WHO for the first time has appointed a chief nurse, your question was, what is WHO doing? When WHO for the first time has appointed a chief nurse, my friend and colleague Elizabeth Ero, I think that sends a signal about nursing leadership. When WHO member states pass a health and care worker compact, which talks about the role of nurses and midwives, and last year the future directions for nursing and midwifery, I think that says something about their importance. It creates an enabling environment. So those are the types of things I think WHO is doing, in addition to its workforce thing. At the end of the day, you know, a WHO election it's like a Security Council election. Now it is. It's one member, one vote, secret ballot, 194 member states. So having said what I said about Dr. Tedros, whose leadership obviously I greatly admire, he's my friend and my boss, having said what I said about the enabling environment, if you will, that WHO Secretariat and member states are creating, at the end of the day, it's an election. And the nominations come from member states. So the question now needs to be turned to those member states who will nominate people who are nurses. And as a very practical matter, that's what needs to happen if we want to fulfill that first, which I think I agree with you, Dan, is a very, very important first. For exactly the same reason, as I said with Dr. Tedros, it's because of the authentic experience of nurses and midwives in the care of people. And by the way, just to close off this answer, I think it connects with some of the themes I was mentioning during the talk, in the sense of equity, in the sense of essential workers, and in the sense of leadership. So that's how I would respond to your very, very excellent question.
And I appreciate that. I appreciate that, Dr. Singer. I'm curious, just as a follow-up, if it is an election process, then of course visibility is important for an election process, right? So what is the WHO doing to put nurses in visible leadership positions so that they would then be eligible to stand for election? Because if nurses are spending a lot of time in the trenches on the front line, they might not be as visible in those second and third tier leadership positions. So can you speak to the fraction of nurses that are in visible leadership positions within WHO in addition to the chief nurse?
Yeah, that's a great question. And I don't have the percentages off the top of my head, but that would be a good one to pursue. That would be a very important one to pursue. In our health workforce department, we do very much promote the role of nurses and midwives. And I also want to highlight, Dan, that if you look, I'm just going to speak empirically because I don't want to prejudge future elections. As I think everyone here knows, Dr. Tedros was just reelected for a second 5-year term by the World Health Assembly, which is gratifying. So what we're talking about presumably is something 5 years from now. But if you look at the history of WHO Directors General, just to highlight that they don't always come internally. So your point is important, and we should track that number, and not only overall, but as you point out, in leadership positions, in addition to the chief nurse. And at the same time, we should also realize that it's also the chief nurses, the leadership positions nationally in countries that are very important. And not only the chief nurses, but in fact, you know, Dr. Tedros was not only the health minister, but before he became the director general of WHO, he was the foreign minister of Ethiopia. And then before that, of course, Margaret Chan was leading a public health unit, and before that, Dr. Brundtland was the Prime Minister of Norway. So just to recognize that sometimes, and in the middle there was J.W. Lee, who actually was internal to WHO. So just to recognize that sometimes it's internal leadership in the Secretariat, if you will. Sometimes it's external leadership, including in high office in countries. And I go back to the national point, because at the end of the day, it's the national governments. And I didn't fully appreciate this before I got as involved with WHO. I'm not a WHO lifer, by the way. I only came there about 5 years ago. I had some engagement through collaborating centers, et cetera. But at the end of the day, it is the national governments that nominate directors general of WHO. And so the real question, to look at is foreign ministers around the world, prime ministers around the world, parliamentarians around the world. That's at least as important to look at, if you will, as chief nursing officers, either within WHO or outside of WHO and WHO technical staff in the Secretariat. So you're casting a wide net in your campaign, Dan. And I think as you're looking for candidates, that's the way to look and the way to think about it. But to come back to your main principle, what I was really trying to say earlier is leadership is terrific when it's grounded in authentic experience. And Dr. Tedros had a particular type of authentic experience that I think served him and the world and WHO extremely well. And the authentic experience of nursing and midwifery also falls into that category, as is implicit in the questions that you're asking. So thank you very much for those. You're asking very, very important questions. Yeah, thank you.
Do we have any other questions or comments from the audience? Yes, of course.
Hello, and it's a great honor to have a possibility. Just a comment, not question. Yes, I completely agree. I have a colleague that is a national officer at the World Health Organization for Croatia, and she was nominated, recommended by the Ministry of the Health, and also needed to be recommended by the president of our Chamber of the Nurses and a head nurse of University Hospital Center. So it's not easy to ask for a nurse to get confirmation and support from all important bodies to be an officer at World Health Organization. But it depends about nursing. We are talking about leadership. I'm proud to say that in this moment, I'm involved in 2 working groups at World Health Organization. And this is something, it depends on you. Are you willing to work? If you're willing to work, it's not always just leading. You do not need to lead. You need to work, and that way you will promote nursing. So that's only my comment. Thank you.
If I may, I'm so glad you made, I'm so glad you made that comment, because you almost said what I was going to say, which is WHO is you. So it's you, it's all of you, it's all of us, actually. Because remember what WHO is. It's all the member states in the world. 194 countries are members of WHO governments. By the way, that's a huge source of comparative advantage, to have a place that 194 governments can come and discuss health issues. And it was very important during COVID. It's the member states, it's the Secretariat, which is about 8,000 people, if you will, 1/4 at headquarters in Geneva, but 3/4 at the 6 regional offices and the 151 or 2 country offices that are, if you will, employees of WHO in one way or another. But more to the point, it's the partners that work with WHO and with those member states, including nursing and midwifery associations like yours. It's the group of those that have formalized it, like collaborating centers, but also the group that are just informal, civil society and other partners. And it's also all the committees. And I think you were describing this as well. The technical committees very broadly because WHO is also a normative organization, which is one of its comparative advantages. So it relies on consensus from technical and professional experts. Like, for example, there's the emergency committee that was deliberating yesterday and will, I think, release. I haven't seen it quite yet, at least not before we got on this video call. Its recommendations to the Director General about monkeypox. Those are all people, none of whom work at WHO, all of whom are experts in universities and different places. So WHO is all of us, and that was your key point, and I really want to just reinforce that key point. I also just want to say that even though I pointed out that the Director General is elected, and by the way, the regional directors, the 6 regional directors are also elected, those other 8,000 people are appointed through, very fair and competitive and open search processes, as was your colleague, I'm sure. So thank you for that comment. I thought it was terrific. And your headline of WHO is, it's not me, it's all of us. And I think that's the key question. And I'd invite everybody in the room to get more involved in WHO. And thank you so much for that comment.
Thank you. Any other final comments or questions? No? Okay. So thank you very much for joining us this afternoon, perhaps morning in your time zone. We really appreciate your time, and I'll bring this keynote address to a close. Thank you, everyone.